Alright, so Dr. Gomez joins us from UCSF Fresno. I just shared with you all. They have a very robust primary care residency program. Yours is in family medicine and community medicine. He's going to be sharing with some thoughts with you from that perspective, but also from the perspective of working on the GMEC of one of our teaching health centers. And so he is going to share with you perspectives from both angles, and I just want to share with you that he is actually also the program director for the California AHEP program, so it's a partner to CPCA, many regional consortia, and health centers as well. So with that,
thank you. Hi again, everyone. So a little bit about my day job. So UCSF Fresno Family Medicine, based in Fresno, Central Valley. Been training residents for about 40 years. UCSF Fresno is kind of what you would call more the kind of traditional hospital-based, university-based program, and gets its funding through the Medicare program through the hospital. So we actually, recognizing kind of the needs of the area, our program began partnering with community health centers and rural health systems more than 20 years ago. So we kind of recognized the importance of placing our graduates in that space. And the mission of the program really is exactly to train, fantastic, to train residents to work in rural and underserved settings. So that's really our primary goal and mission as a training program. We have a long history of placing residents exactly in that space, primarily in the Central Valley. Our program has graduated about just under 400 graduates now since the program started. When I came there in 2000, we had 11 residents per year. Now we're in the process of expanding to 15 residents per year, which will make us tied for the largest family medicine program in the state. Over 50% of our graduates are right there within the Central Valley. Just in the time frame that I've been there, we've placed 75 graduates and about 80 graduates in community health centers and FQHCs. The ones that don't stay in the Central Valley, they go predictably to where you might expect. They go to the Bay Area, they go to LA. 99% of our graduates stay in California. We have 3 separate we would call pathway training sites. 2 are based at FQHCs and 1 at a rural hospital-based rural health center. And we've had these 3 sites now for probably over 25 years. In 2016, so I don't know if you guys covered this yesterday, but in terms of residency funding, really the funding that's available through hospitals has been capped since 1997. So pretty much any kind of expansion of training programs has had to solicit other kind of sources of support. So in our program, we weren't really in a position to kind of just recruit, a bunch more residents to our training program, but we recognized that, hey, there is a real significant need for more primary care physicians in the Central Valley. So what we did is we partnered with, at the time it was a healthcare consortia, and what I'm going to talk about today is FQHC in the Central Valley, to actually develop a teaching health center residency program based at Valley Health Team, which is right next door to us in Fresno. And reason for that is we just realized, hey, it's a lot better to graduate 19 or 20 family physicians in the Central Valley so that we can keep them here rather than have those potential residents go somewhere else and stay somewhere else. Because most of the data around residency training really speaks to the majority of residents, they end up practicing close to where they graduated from. So the way we support that program is we provide a lot of the ambulatory specialty and pretty much all of the inpatient hospital-based training for the residents. Their residents participate in our educational half-day series. We have like protected time for educational half day for our residents that their residents come to every week. And then we also offer some additional venues for faculty development. We have a annual research forum and quality improvement forum that we invite that program to come and participate in to really kind of help fill out the additional needs of training their residents. So how the program started, very noble beginnings. Basically, it began as a training site to really help residents that were already in an existing teaching health center to complete their training because that program had lost accreditation. So they really stepped in to allow the third-year residents to really finish that training. And then after going through that process, they really kind of saw the value in really trying to retain, keep this program alive. And so they decided to take the plunge to start their own program and had a lot of interactions with Kiki since then. So in addition to all the new requirements for a new sponsoring institution and a program that Dr. Carriero talked about, they also had the additional task of trying to convince the ACGME that this is actually a new program. We're not just extending this old program that failed. We're not trying to get around the rules, right? And so what they did is they completely revamped their curriculum, their organizational structure. They really provided a lot of support for the staff, the operations, support for the faculty. They pretty much redesigned a lot of the policies and procedures. Heard a little bit earlier about how you really have to go through that whole list. Many of them were adapted from our program and just kind of, changed or tweaked to kind of fit their needs. They built a brand new site to support the residents. So they were in the process of evaluating, in terms of their expansion, building a new clinic site. And they're like, hey, well, we're going to do this. Let's make this the residency training site. And then they had to reestablish MOUs with the hospital and academic partners. And so with all of this, they made a really kind of convincing story to say, no, hey, this is actually a new program. And they got accreditation, which was great. So now they got a program. So now what? So you heard a little bit earlier about the GMEC. As you've kind of heard, it is very key. The buck stops with this entity. The ACGME requires it to oversee training programs. Most of the type of programs that you would be all involved with, if you want to start your own program, are really going to have one program to oversee. Some university programs or GMEC may actually see as many as 30 or 40 different training programs. At UCSF Fresno, there's 9 residency programs and 17 fellowships. The GMEC also oversees 3 PA residency programs that we have there as well. So that GMEC is kind of busy. The GMEC meetings, happen every month. They're usually about 3 hours. So as you heard already, the DIO, designated institutional officials, usually the dean of the school or the CEO of the organization, or their appointee, residency directors and key personnel partners, and then residents have to be at the GMEC meeting. So you have to have learners that are overseen by the program participate in the meetings, and they have to participate meaningfully to the discussions, right? So if there's some issue about patient throughput, patient safety, whatever, you need to be able to validate that the residents were able to contribute to the discussion, that their issues were being heard. So I won't go through this list. This is kind of similar depth to what Dr. Carriero showed us earlier. The GMEC does a lot of different things. Big thing here is addressing resident concerns and then overseeing the performance of residency leadership. That's also something that can be a little bit challenging for smaller programs. It takes you a lot of effort to find what you think is the right program director, but what if the program doesn't really perform? What if it's not following the direction of the institutional leadership? What if people are leaving the program mid-training? So these are all things that that the GMEC is ultimately responsible for overseeing and for correcting if they need to. So I participate on the GMEC at the Teaching Health Center program at Valley Health Team. One of the, kind of a short list here of really the biggest challenges that smaller programs tend to have. The biggest one is around faculty and staff recruitment. So, you really not only need to identify people who, might want to teach a half day a week, you really have to identify people that is kind of why they're there. That is their reason for being, the core faculty of the program. I don't know if you guys covered those definitions yesterday, but basically core faculty, depending on the size of your program, you're required to have a certain number of certain ratio of core faculty whose majority of their time is spent in contact with residents or managing the residency program. So you have to have the right people for that kind of position. Usually those people are not people who are just, they just want to see patients. Usually you're getting somebody who's really, they want to be an academic, have an academic role. Small group, word gets around. So really important for morale and communication. With small programs, small number of residents, everybody knows everybody's business. So it's very important to kind of, keep an open and kind of transparent environment. Being able to provide adequate support and personnel for administrative time and allowing the program director and faculty core time. So kind of like what we touched on before, protected time means time where they can actually do things like work on lecture development, develop curriculum, advise residents, participate in meetings to establish new partnerships, basically not patient care. And then, of course, the GMEC is ultimately responsible for making sure the programs meet the ACGME requirements. And for most programs, if not all, there's at least some hospital-based and specialty-based training that's required that is not really going to be directly available to you in your own house. So you're going to need to, connect with a specialist physicians that you may not directly employ. You'll need to have some arrangements with a hospital or different kind of inpatient care centers, emergency rooms, etc., so that the residents can receive the full scope of training that's required. And then community physicians or established university-based programs really just kind of depends on your environment. Usually, I put this last line here about virgin hospitals. So that's really kind of a different discussion. Some of you are more rural areas. You may be close or it'd be an opportunity to partner with a hospital that has never had residents. That is a little bit of a different discussion because a lot of other factors that impact the ability of those hospitals to train future residents if they don't do it right when they start. So that's probably a different discussion. Usually the hospitals that you will all be working at should be hospitals generally that already have residents there. And if that is a scenario for you, then you probably should be talking to teachers. All right, so view from the other side. So academic primary care residency programs that are looking to partner with CHC. So when they come to you, or you're introduced to a program that's looking for this, or is willing to, or you're going to them and expressing an interest in this. So what do they want and need? So primary care training programs, like I mentioned, hospital numbers are capped since 1997. Depending on where you are and the kind of flexibility of the sponsoring institution, how much grant funding they have, and so forth, they may have very limited capacity to train residents at external sites. And it's particularly difficult for primary care programs that really want to train physicians to work in primary care settings if the only exposure they can give to residents is a hospital or a hospital-based clinic, which is a completely different environment, as I'm sure all of you know. So this is one value that they see is they like to be able to put residents in different settings. There's also much more interest in validation in the family medicine literature and certainly across the board on really looking at value-based and patient-centered care. And doing that within the context of an FQHC is a lot easier. People are thinking more along those lines than a hospital-based clinic that has one MA for 7 providers. And then the diversification of partnerships. So, medical education, talking with hospital CEOs, a lot of these hospitals, medical education is not sacrosanct. So they're looking for budget cuts. So just a personal story. So about 7-8 years ago, our sponsoring institution, our hospital, had a $10 million drop. They came short of budget by like $10 million for 1 quarter. And so they went to our DIO and said, hey, we're under budget. We need to cut costs. We want to cut your family medicine program. Just like that, right? Because they cost a bunch of money and, they don't do anything in the hospital for us anyway. Okay, so that was the attitude. So thankfully our DIO was like, no, you don't get to decide that, because our sponsoring institution, this is why Kiki says we're kind of a strange bird, is really, even though funding comes through the hospital, the sponsoring institution is the University of California. So even though our funding comes through a hospital, it's really kind of a pass-through to our organization. So if they really wanted to reduce the number of residents by 45 residents, it was going to be up to the university what programs they were going to reduce. So again, diversification of partnerships. I learned very quickly that day that it's not a good idea to have all your eggs in one basket. So having multiple partnerships, multiple partners that we can kind of spread the cost of support of the residents was an important lesson for me as an early program director, and so that may be also a good reason for looking to partner with you guys. So value of partnerships to the academic institution, again, so challenges. So one of the things that we often face with new partners is residents aren't students. So they are actually doctors. They're kind of in this kind of weird hybrid role between practicing and studenting. Support for residents and the fact that to train doesn't necessarily correlate with an increase in visits or even in access in the short term. And so it can be hard for academic institutions to otherwise sustainably support and make a case for CHCs to justify their governance. So basically what I'm saying there is it can be hard from the community health center side to really justify paying for the residents, paying for the faculty, when you could just be paying for a provider who's just going to see more patients anyway, right? There's also a little bit of loss of control by the academic institution over the teaching environment, but they're still responsible for it. So like Dr. Carriedo said that, she's got a great relationship with her program director at the family medicine program. That's clearly what you want, so that there's a lot of communication, so that the program director knows exactly what's going on with the training of her residents, because she's going to be answerable to it. If the residents have an awful time at your health center, it's not the health center that's going to really have any fallout from that. It's the program that's going to get their accreditations in. So that is potentially a risk when programs are externalizing some of their training to community health centers. And then, of course, like I was mentioning, there is a culture shift really for a lot of sites that are really looking to do this, to really look at, what's the value of the partnership? Is there the teaching and care quality that's being trained and learned? Is that going to offset the, whatever crushing need there might be for patient care access? So that's a pretty brief overview there. The main thing with, the participation that I've had with the teaching health center has really been again, it's been mentioned a few times, are really about support for figuring out the best way to support the residents and how do we make it work within our operation. And the FQ that I'm working with, the Valley Health team, they really throwing in a lot of resources, a lot of time, a lot of expertise into making this work the right way. And it's paid off. They've gotten their graduates to stay. Questions?
Can I just add something to what you
Sure.
just said? One of the things I learned in that experience, they didn't have to have Dr. Gomez on their GMEC. It wasn't a required position. But they chose to do it. And the value add of having an academic, at that point you're program director,
Right.
on that unit has been huge, huge. Because you've got a F2HC that's extremely well-intentioned, but the DIO has never been a DIO before. She's not from the world. She's a suit like me. She's not, she's an executive director. She's not a physician. Got a program director who's relatively new on the scale of program directors and have been through some horrible wars to get to this point. And I've acknowledged his calming influence, has been able to help them see things that they wouldn't have seen or wouldn't even have known to ask. And it's given them additional perspective and knowledge, and at times it's okay, you'll be all, it's just been huge. So whenever possible, after that point, I've always said, try not an academic on your GMEC, because there is if you're an F2HC.
If you're in an area that really is struggling for primary care access, for sure, most academic physicians from university-based programs, they're in the same situation. They're in a place where, hey, we would like to expand our program, but there's no funding to do it. And so, and because it's a university-based program, they can't take advantage of some of the avenues for funding, like the Teaching Health Center, right? When the Teaching Health Center funding first became available, man, the university had attorneys and all kinds of people trying to kind of figure out a way that we could leverage the use of that funding to expand our program. But ultimately, we decided it made a lot more sense to partner with a community health center and integrate our training programs. And that's the thing. That is really the challenge. There is if you're able to really kind of have that collaborative partnership with your hospitals, with your other potential training sites, that goes very far in the success of the program. Plus, it also gives you an avenue to access graduates from those other programs if you're working together, right? So, for example, in our program, we have UCSF residents training alongside our VHT residents. They, do a lot of stuff together. They socially do what residents do. and when we're recruiting, we're looking at their residents just like we're looking at ours. And that's an additional added value. So even if you think you only have the capacity maybe to support a minimum size program, 4 residents, 6 residents, by opening up that partnership and making it possible, like if their residents want to do something with your institution, then it also, helps to solidify the partnership and gives you access to a broader group of people to